Hi, my name is Michaela Howe, and my project is on a dual strategy for mental health support in children and adolescents. So some background. Mental health disorders in children and adolescents is a growing concern, with increased incidence of anxiety, depression, and even suicidal ideation. School is a primary access point for many children, so oftentimes that's where the mental health disorder is identified, and first interventions are implemented. Physical exercise has been shown to improve mental health outcome through better emotional regulation, improved social functioning, a reduction in depressive symptoms. Increasing preventative mental health services in school while also encouraging participation in sports may serve as a dual strategy to address this growing public health concern. So some incidence and prevalence. 1 in 5 children in the US have been diagnosed with a mental, emotional, or behavioral disorder, with ADHD being the most common and affecting the most children. There was a recent rise in mental health crises during and after the COVID-19 pandemic. So mental health disorders are more commonly reported in adolescents, ages 12 to 17, with girls being more likely to report anxiety and depression. However, youth at risk for developing a mental health disorder include those with chronic illnesses, disabilities, and those who come from low-income households. Urban schools have more students, so they're going to have a higher rates of mental health conditions. However, rural schools have less students, so they have lower rates of mental health conditions, but they have limited access to mental health professionals for those who do have mental health conditions. And the COVID-19 pandemic was an isolating time for everyone, but this is especially true for children who had classes on Zoom. They couldn't interact with their friends and couldn't interact with their parents, depending on their parents' line of work. Although the pandemic is over, the after effects of the trauma may still be felt today. So some leading health indicators. Oftentimes, kids who are battling a mental health disorder will miss school, and when they do come to school, they oftentimes won't participate in classroom discussions. With a lack of attendance and classroom engagement, the grades often start to suffer, so we'll see a decrease in school performance. In summary, there's more absences, less classroom engagement, and poor school performance. So the social determinants of health, SDOH, impacting mental health in youth include social community contexts, economic stability, education access, healthcare access to neighborhoods. So for social and community contexts, youth facing trauma, violence, or family instability are at an increased risk for anxiety, depression, withdrawal from school or sports. For economic stability, low-income families often can't afford private care or pay-to-play sports, so free school-based programs may close this gap. For education access, over 50% of U.S. children with a mental health disorder do not receive treatment, and for many, school is their only point of access. Barriers to care include lack of trained staff and mental health stigma. For health care access, mental health provider shortages, especially in rural and minority communities, limit referral pathways, even when problems are identified. And then for neighborhoods, in communities lacking green space or safe recreational areas, kids are less active, which leads to worse physical and mental health. So some social ecologic model contributions. We have individual, interpersonal, organizational, community, and policy. So on the individual front, some children don't recognize emotional distress or they're afraid to talk about it. Education builds mental health literacy. On the interpersonal front, supportive relationships with parents, teachers, or coaches are protective. Sports build social connectedness, and reduce isolation. On the organizational front, school can embed mental health care in the school day, reducing missing class time. And then on the community front, community resources, partnerships, and attitudes shape what services are available. And on the policy front, funding and educational mandates impact what services are available in the school system. So the two objectives that I'm focused on for Healthy People 2020 or 2030 is EMC DO6, which is the increase in proportion of children and adolescents who get preventative mental health care in school. So this matters because mental illness often begins before age 14, but many youth go undiagnosed and untreated. The current status is 49.4%, at baseline with a target of 54.3%. This objective emphasizes prevention, not just crisis intervention. My next objective is PA12, which increases the proportion of children and adolescents who play sports. So this matters because physical activity is linked to lower depression, better sleep, and increased self-esteem. Currently, the baseline is at 56.5%, and target is 63.3%. Because we're seeing a stagnation of children who play sports, an intervention is needed to reduce barriers such as cost, time, and facilities. So this leads me to my project proposal called Mind in Motion, a school-based mental health and physical activity project proposal. So this project will increase mental health screening and early intervention within schools, increase sports participation by reducing access barriers, improve youth mental health outcomes and school engagement by integrating mental and physical wellness strategies. So my target area is Milwaukee County, Wisconsin. This has urban schools, but they have pockets of poverty and health disparities. In addition, Milwaukee also has high rates of adolescent mental health, ER visits, significant racial disparities in sports access and mental health outcomes, and there's an opportunity for scalable models in school districts as well. So my program goals include increased mental health screening and early intervention through embedded schools, counselors, and social workers. Increase sports participation by reducing access barriers through starting clubs, offering gear, and ensuring gender and cultural inclusion. Improve youth mental health outcomes and school engagement by integrating mental and physical wellness strategies. So I'm going to do this through implementing these steps and processes. So the first 1 to 2 months will be a planning phase where I would like to conduct assessments, gather baseline data, and meet with school administrators and parents. Months 3 to 6, I would like to develop the program further by hiring mental health professionals, training teachers and staff in trauma-informed care and youth mental health first aid, and creating a safe and inclusive after-school sports teams. At month 5, I would like to launch the program. Each semester, I'd like to incorporate mental health screenings through the PHQ-9A and GED-7 to track participation in after-school sports and provide family education sessions. And then any students that are identified as high risk through screening will be referred to clinical mental health partners. Okay. So how does the program align with the 10 essential public health services? It aligns through the following. So for access and monitor, I'll monitor health through screening, sports participation, and tracked attendance. For diagnose and investigate, this will be done through identifying trends in depression and anxiety. For inform and educate, I will inform and educate parents, students, and teachers. And then community partnerships. So I will mobilize community partnerships with recreational centers, public health departments, and clinics. And for policy development, I will develop policies that will influence school wellness policies. And then enforcing laws, again, we'll enforce laws that will align with state school wellness policies. And then link to care. This will be done by connecting students to outside services when needed. And then I will ensure the workforce by building an internal school capacity with trained staff. And we'll evaluate through data-driven improvement every semester. And then research will be done through academic partnerships who will evaluate and publish results. Okay, so the partners and resources that I will be using. So resources and partners include public health departments like the Milwaukee Health Departments for surveillance, academic partners like University of Wisconsin-Milwaukee for evaluation and interns, and then nonprofits like YMCA and Boys and Girls Club for program staffing and facilities. And then clinics like Children's Wisconsin for referrals and crisis care, and the school district for administrative buy-in and staff support. So some interventions on the population level. This would include mass mental health education campaigns, an all-inclusive after-school sports program, monthly community mental wellness events, clinic level or on the clinic level / school level, routine screenings for anxiety and depression, on-site therapy or counseling, and then a tiered mental health interventions. So some supporting literature. In the school-based mental health services, a research review by Whittaker et al. Embedded school services reduce emergency mental health visits and increase attendance. From Physical Activity and Mental Health by Rosenberg et al., youth who play sports have lower rates of depression and higher academic performance. Then from Toward the Integration of Education and Mental Health and Mental Health in Schools by Atkins et al. Early screening and brief intervention models reduce costs and improve quality of life. So some needs assessment. Tools used in the needs assessment include surveys from students, staff, and parents, school health records, and community maps of resources. Data will be collected from Wisconsin Youth Risk Behavior Survey and school district health records. So how is this all going to be done timeline-wise? In months 1 to 2, the needs assessment will be performed and stakeholder meetings will take place. For months 3 to 4, that's where staff will be trained and hired, and sports clubs will be launched, and screening will begin in about months 5 to 6. For months 7 to 1 year, monitoring will be done for progress, and adjustments to the program will be made as needed. And after 1 year, an evaluation will be done, and data will be published with expansion of the plan performed based on the data collected. So for evaluation and quality improvement tools would include PDSA cycles for process improvement, feedback loops with student advisory panels, and quarterly dashboards for real-time data tracking. Outcome measures will be measured by percentage increase in mental health screening access, change in average PHQ-9A/GAD-7 scores, sports participation rates, and attendance and disciplinary data. And the sustainability metrics would include cost per student reach, staff retention and satisfaction, and grant funding leverage ratios. Okay, and then those are my references. Thank you so much. That's all I have for you.